Okay, so has that gone to the next slide?
Yeah.
Sweet. So these are the stuff we're covering today, and obviously there's a lot of conditions of respiratory medicine, but I've handpicked the ones that I think are constructive to go through and the most important ones and the most likely you're going to get examined on, whether that be the SPA or the OSCE. Dr. Dave can't see the group chat. Okay. Well, if we get any questions for Dr. Dave, especially, we'll just should we just read them out to Dr. Dave? Is that all right, Ed? If she can't see the
Yeah, that's fine. Sorry, just to let you guys know that if there are any questions, then someone will just have to highlight it because I can't see any questions. I can't see any chat, I'm afraid.
Sure, no worries. Thank you again for coming along.
That's all right.
Okay, so let's start. So first, SPA. I won't read it out because I know some people can't concentrate when somebody's reading it out to them, but I'll just put a little timer on.
And just to say, we've been a bit lazy. We're going to keep reusing and rerunning the same poll because it's just easier for us to do it that way.
So yeah, fill in the poll when you feel like you've got an answer. All right, should close the poll now. So what I like to do with my SBAs is that I quite like to, there's going to be so much content in a STEM, to kind of just highlight the little specific bits and bobs that you need to be just very good at honing in on. So here, 27-year-old, I think age is so important. So 27-year-old woman, she has shortness of breath, wheezing and a cough over 3 days. She reports exposure to a person who had a runny nose and a hacking cough. It's disrupting her sleep pattern, worsening her job performance. So it's affecting her life, essentially, and she's able to speak in full sentences. The best initial investigation. So the condition that we're talking about here is asthma. We can kind of see that with the fact that she's having the wheezing, the shortness of breath. She's 27 as well. It's exposure to someone else, and I think at this point it's quite good to highlight wording of SBA questions. I can't remember back to pre-clins, but wording is so important in UCL clinical examinations because you know, everything is in it. So best initial investigations, I've highlighted initial, and that wording will come up in the exam. And it's quite a good thing to come up, to be honest, because you know that initial means, you know, one that you can do at the bedside. So it's not in this question, but if it was, if one of the options was, you know, take a biopsy, most likely, even if you don't know the answer at all, it's not going to be an initial investigation because a biopsy is quite an invasive procedure. So peak expiratory flow is the correct answer in that one. So we just go on to talk about asthma. So by definition, recurrent episodes of dyspnea, shortness of breath, cough and wheeze, and it's caused by an intermittent reversible airway obstruction and hyperactivity. There are 3 pillars of causing the airway narrowing, and that's bronchial muscle contraction, the mucus production that builds up, and mucosal swelling and inflammation. So, as I highlighted before, stems will be long and you need to be efficient in trying to find out which words kind of correlate to which disease. So these are the buzzwords that I've found by doing like all these question banks, etc., in the UCL papers that normally point towards asthma being a very likely differential. So it's something that's exercise induced, caused by precipitant, there's a diurnal variation, so it changes, the peak flow changes during the day. Disturbed sleep, for example, nocturnal cough, other atopic diseases that the person might have. So they might have eczema, allergy, hay fever. So they could be like somebody who is prone to those sort of reactions, which can cause asthma. Acid reflux as well can be quite a rogue thing to have in there as well. So symptoms and signs, we've talked about this before, and it's come up on the SBA. So symptoms such as cough, wheeze, sputum, intermittent shortness of breath. Signs, so this is more for your OSCE. So you can get a hyperinflated chest, tachypnea, a hyperresonant percussion note, so that can be due to the hyperinflated chest. And you can get, obviously, that wheeze that's audible through auscultation. So the worrying signs in asthma, and I don't know if I'm allowed to say this, but this was a question in our finals paper that they basically gave us a stem of people, of someone who had asthma, an asthma attack, and you had to basically say whether it's moderate, severe, life-threatening, or near fatal. And this is a really important skill as a junior doctor, because you're going to be that person who will see potentially that patient first, and you need to basically know who you need to escalate the problem to. And so the way I like to think of it is a severe attack, there's a lot of parameters involved. So, above 110 beats per minute, respirate above 25, peak expiratory flow between 33 and 50%. Can't complete sentences, etc. So there's a lot of parameters there, but life-threatening attack is more what the patient looks like. So obviously you've got the peak expiratory flow of less than 33%, which is obviously low. But you've got stuff like confusion, exhaustion, cyanosis, and then obviously looking at the carbon dioxide levels as well, which is the main thing that causes the confusion and the exhaustion is from having to breathe really hard and really deep quickly. So the way I like to look at it is life-threatening things are more what you can see of someone, going to that phase where they're getting tired and they can't do the respiratory effort themselves anymore. But yeah, I think this is really worth learning. Investigations. So I split this up. You can do the three main ones: peak expiratory flow. So that's the initial one. And this basically gives you a really good idea of if they've got diurnal variation. So if they've got more than 20% variation in peak expiratory flow over the course of a day, there might be an asthmatic picture. Sorry if you can hear that. It's a busy road to Camden. Spirometry would show an obstructive defect. So as written here, the FEV1 and the FEV1 FVC ratio is decreased. Spirometry can also be used to do a bronchodilator reversibility test. And essentially what happens there is somebody gets their FEV1 measured, then they get a hit of salbutamol, and then they get their FEV1 measured after that. And if there is an improvement, that basically means, okay, there's some sort of reversible airway obstruction going on here. And the figure for that is more than 12%. I don't know if you need to really remember that, but maybe just remember the concept of it. And then fractional exhaled nitric oxide is basically, you just need to remember that a high nitric oxide shows inflammation. And that's that really. So the management, and this is like every year, because of respiratory asthma and asthma in pediatrics in 5th year, and then obviously learning asthma again in final year. Every year, this is like always a contentious debate as to what is, do you follow BTS or NICE guidelines, etc. This is what I would follow, and it served. I think there's no real disputes there, to be honest. And to be honest, I think it'll be really harsh for them to ask what the 4th line management is for someone who's suffering with asthma. So try and remember maybe the first 3 steps, and then it's quite easy to just add them up there afterwards, which is how I like to kind of remember it. yeah, and then at the end, you can add additional therapies like a LAMA or like biologic therapy may even be needed as well if the asthma is that severe and can't be controlled with all those measures. So yeah, that's just something you need to kind of rote learn. These are just there for you to have a look at. It's straight off NICE CKS, and it's just the guidelines. If you're into that much detail, then please go for it. Personally, I find it like a bit off-putting, so I'm just going to skip ahead. But it's there if you need to have a look later on. Okay, that's what we've talked about. Okay, asthma control is really important. So this is important in two cases. For example, somebody could, well, in the case of going to the GP, basically, and realizing when you need to go up the ladder of medication. So losing control, so you need to increase the therapy. So certain factors that make you seem like you're losing control of your asthma would be like waking up at night and having like a coughing at night, using your inhaler 3 or more times a week can show, you know, decreased maintenance of the disease. Asthma attack within the last 2 years, work days missed due to asthma, any changes in exercise tolerance. So, you know, it's basically these symptoms, and it will be quite obvious in an SBA stem as well. It will be something like, oh, this person's on a salbutamol inhaler, but they've recently, you know, had 4 wheezing episodes in the last week, or they've been waking up at night. It'll be something that really like is affecting their functional life. So it'll be easy to pick up those sort of bits and bobs in an SBA stem. And that basically means, okay, what's the next step now? If they're on salbutamol, okay, now I need to add an inhaled corticosteroid. Decreasing maintenance therapy. So this is when you're feeling good at that level and you want to try and decrease what you're having and going down that ladder. So so it basically happens when you're feeling fine for 3 months, at least 3 months, and then you see your GP and then try and see if you can taper things down a little bit. Okay. Fine. Admission and discharge. So when somebody comes, so these are really important, especially as an F1, because you want to know, as I said before, what is an important thing for what sort of situations do you warrant somebody getting admitted for an asthma exacerbation, and those are the criteria there. So features of a life-threatening attack, it should be treatment. Like features of life-threatening treatment should be life-threatening attack, severe attack persisting after treatment, so something that's not being able to get treated, or if they've had previous near-fatal attacks, even if currently it's not as severe, because you're always worried about maybe, you know, there is a chance that they could further deteriorate. Discharging also really important. So when can we deem someone to be suitable enough for discharge, and get them back to their normal lives outside the hospital? So it will be there's certain criteria. So you'll need to be stable on, the patient will need to be stable on regular maintenance therapy for 24 hours. Needs to have a written management plan, and needs to be followed up, basically. And also, I should have added there as well, check inhaler technique is really important for that as well. So we'll go on to this next question. Okay. So that was the answer there. So again, it's another next initial investigation. Bronchodilator reversibility testing can be done at the GP. And so that would be the best next initial investigation. It's a bit annoying. That's why it's the red light. What I want you to kind of take out of that is the context. So we all know that it's asthma, obviously, because I've talked about it for ages now. And, you know, it's got the classic things in asthma, but it's also good to know about where the context is. So in the GP setting, so bronchodilator reversibility testing. So maybe just trialing out the salbutamol, seeing how that affects the FEV1. Okay, here's another one. Okay, we'll move on from that. Is that enough time, do you reckon, to move on? Given enough time?
Yeah, it's all right. We've got a lot to get through, so we might as well keep the pace up.
Okay, fine. So this is what I've just been talking about just now. So they've had a near fatal asthma attack. They've been in hospital and they want to get discharged. Out of all of that, it will be the once stable on their normal inhalers for 24 hours. Cool. Next question. All right, let's move on. So in this question is slightly nuanced. So wheeze, coughing at night. So we know, you know, it could be an asthma, like 21-year-old as well. Looks like an asthma affected student here. Happening over the last month. So you know it's an acute thing. He doesn't have a family history of atopy or any other respiratory conditions. He's just started an apprenticeship in industry. So here's another tip about UCL questions. Most of the time, they're not trying to trip you up. And if there is a bit where it's like, oh, why have they put in that he's just starting an apprenticeship in industry? It's probably relevant. So the best next action would be a referral to occupational asthma specialist, because potentially the apprenticeship that they're doing is causing them to have these asthmatic episodes. So this is more of a diagnosis of occupational asthma rather than inherent asthma there. Okay, last quick one here. Okay, I've actually realised I haven't put the answer slide on, so I'm going to get my thinking hat on for this one. So losing control would be the waking up one night a week with a cough, as previously explained in the slides just before. Right, next SBA. the X-ray kindly given by Radiopedia. Reference in the notes. Mm-hmm. Okay, right. Let's dissect this question. It's a bit of a hefty stem, so I apologise about that. So 61-year-old man, shortness of breath, pyrexia, and a productive cough, giving green sputum. So we think there's something infective-y going on here right now. The cough started 3 days ago. Hasn't gotten any better since. So he used to enjoy playing football, but over the last few years, has become breathless over a few steps. So there's a decrease in exercise tolerance as well, which has been a chronic thing happening in the last few years. He's also got 42 pack year history. That's the clincher for me in this situation. And the chest X-ray, if you have a look here, we can see hyperexpanded lung fields, which is a thing that really shoots out. I mean, slightly flat hemidiaphragms as well. So the most likely diagnosis, if we go through the list here, so an acute asthma episode, we've just gone through asthma, probably not. He doesn't have any history of asthma or atopy, and he's quite old. Pneumonia, it could be. It could be pneumonia. It sounds like it, but if we move on to the next bit, lung cancer, probably not. He's not got any B symptoms. He's got the pack year history, but he's not got B symptoms or like hemoptysis, which is like classic things to be written in SBA STEM. Infective exacerbation of COPD. So that kind of ties in both the pyrexia, productive cough with green sputum, and the 42 pack year history. So that would be my most likely diagnosis in this situation. TB, also a bit of a red herring, visited south of India. But he's not got, again, hemoptysis, weight loss, etc. These sort of questions are annoying because generally it could have been pneumonia, but it's what best fits, and you'll realise like that is like a classic UCL question, trying to be slightly vague and what's the most fitting picture. So let's talk a little bit about COPD. So it's defined as progressive disorder characterized by airway obstruction. So like asthma, FEV1 less than 80%, FEV1 FBC ratio less than 0.7 with little or no reversibility. It's split up into chronic bronchitis, which is I always found it quite a weird definition, but a cough, sputum production on most days for 3 months in the last 2 successive years. And emphysema, which is defined histologically as air spaces distal to the terminal bronchioles. It is associated with a chronic history of smoking. So symptoms and signs. So symptoms, cough, sputum, shortness of breath, wheeze, it can happen. So it's a good differential to have if you have a OSCE, if you have a patient who has a wheeze. Infective exacerbation of COPD is a good differential to have, along with asthma. Signs, so cyanosis, cor pulmonale, so that's right heart failure, a resonant percussion, hyperinflation, which is causing the resonant percussion, tachypnea, use of accessory muscles, so very laboured breathing, and reduced air entry, are all signs of COPD. So you get 2 different types of sufferers, and I think it's slightly un-PC now to call them pink puffers and blue bloaters, but it's quite good for revision purposes in that sense. So obviously don't ever say that to a patient. I've heard some stories that people have done so don't do that. So pink puffer, so you'd get increased alveolar ventilation. You'd get a normal PaCO2 and a normal or low, a normal PaO2 and a normal or low PaCO2. So essentially they're breathless, but they're not cyanosed. And blue bloaters are the ones that you're really like worried about. So they'll have decreased alveolar ventilation, a low PaO2 and a high PaCO2. So they are cyanosed but not breathless, and instead of they go into a state of relying on a hypoxic drive, which is not what we normally do. So bear with me on this. A person who doesn't have COPD will have more of a hypercapnic vibe, hypercapnic drive. So when CO2 goes up in our body, we're going to try and blow it off. And when CO2 is low in the body, our breathing rate will decrease. Whereas in somebody with COPD, because they're having such a hard time breathing off this CO2, their body adjusts in a way that they now rely on carbon dioxide levels to tell them they now rely on oxygen levels to tell them whether they need to breathe higher or lower. So if somebody has got a low oxygen level, then they will keep on trying to breathe as much as they can, and they start to become insensitive to carbon dioxide, and that can cause situations where carbon dioxide can go really high levels into the body because they have no hypercapnic drive anymore because they're desensitized to the carbon dioxide. And this is obviously quite a worrying situation because as we explored with asthma, high PaCO2 levels in the body are, reasons that somebody will have to then escalate their treatment into ITU potentially if they keep on getting a build-up of a PaCO2 in their body. So COPD investigations. So I've just listed what I think are really important investigations in COPD and why they're important. So FBC, so exclude secondary polycythemia. So in COPD, because you're not getting enough oxygen in the body, your red blood cells react to that by increasing turnover and getting more blood cells in the arteries. That can give you a raised hemoglobin count, which is not great for the body because that can cause more clotting, which is obviously not ideal. ABG, so as explained before, decreased oxygen levels plus or minus hypercapnia. So what is really important, especially in a infective exacerbation or an acute attack of COPD, is important to take the ABG levels, because if somebody is given, for example, salbutamol inhalers or ipratropium bromide inhalers to try and get their lungs to start functioning a bit more, we need to monitor the ABGs to see whether they're going, one, seeing whether their oxygen levels are getting increased, and two, seeing if their carbon dioxide levels are decreasing. And now, if there is a state where the carbon dioxide levels are keeping on shooting up, we need to now escalate onto better measures, basically. But for example, that is NIV or that is BiPAP or then ITU. So that is why it's really important to take serial ABGs in these sort of situations, in asthma attacks and in COPD. ECG core pulmonale, so that's right-sided heart failure, and that can be caused by congestion in the caused by the polycythemia as well. Chest X-ray, so you can get hyperinflation, flat hemidiaphragms, as shown in the last X-ray. Large central pulmonary arteries, I think it was really hard to point that out. Bully as well. And spirometry obviously would give that obstructive picture. And then the CT scan would show, airway wall thickening, scarring, airspace enlargement. So this is the management of COPD as in a general term. So conservative stuff, smoking cessation, exercise, pulmonary rehabilitation. Medication-wise, you can give mucolytics, which help with a chronic cough. You can give diuretics for the edema caused by the cor pulmonale to the right side of heart failure. Flu and pneumococcal vaccinations are needed as well. Bronchodilator therapy obviously is very important, and long-term oxygenation therapy is really important. So the last two there, I should have put that at the top, but the last two are the most important ones for you to learn. And so this is the bronchodilator therapy, going a bit more in depth. So SABA or SAMA is the first line treatment. And the next line is dictated by whether or not your patient has a diagnosis of asthma or atopy. So in that handy little bubble there, or cloud, it will show you things that you need to pick up in an SBA stem to make you realize, okay, this person's got a slight asthmatic picture or an atopic picture. So that's a high eosinophil count, variation of FEV1. So remember I talked about that diurnal variation stuff there. That's what I like to remember with this sort of stuff. Showing like an asthmatic picture. So if there are no asthmatic features, slash features suggesting steroid responsiveness, you add a LABA and a LAMA. So a LABA being a long-acting beta agonist and a long-acting muscarinic antagonist. If they have those asthmatic features, then you add a LABA and an ICS. So the way I like to think about it is, if you have a little think back to the asthma guidelines, an ICS is the first thing that you give after the SABA. So trying to extrapolate that onto COPD, you know that an ICS, along with a LABA, which is what you always give in your second line for COPD, whatever their asthma or atopic picture, you always give the LABA, and then you can either give an ICS if they've got those asthmatic pictures, which makes sense because in the asthma ladder, ICS is quite high up there, or you give a LAMA if they've got no asthmatic picture. And then if the patient remains breathless or still having exacerbations, you can add the LAMA on. And that's essentially the steps of bronchodilator therapy for a patient with COPD. Long-term oxygenation therapy. So this is offered to a patient when their oxygen levels are less than 7.3, or their oxygen levels are between 7.3 and 8 if they've got specific comorbidities, for example, pulmonary hypertension, which is a cause of the cor pulmonale, polycythemia, peripheral edema, or nocturnal hypoxia. So as in like waking up at night, feeling breathless, etc. So what happens in long-term oxygenation therapy is that the patient is given oxygen 15 hours a day to maintain their oxygen levels above 8. And the 3-year survival rate increases by 50%, which is huge. But, and obviously, like sitting in on these clinics that I was able to a couple of years ago, it is such a, for some people, such a chore, and especially for like partners as well, because it's quite a loud machine, and 15 hours is such a long time to be on oxygen for, and having to do that day in, day out is just like a crazy thought for me. But it does increase survival rate. And then the oxygen levels are worked out by doing ABGs on 2 occasions, at least 3 weeks apart. So that's a little bit of a nuanced thing that you need to remember. But yeah, that's long-term oxygenation therapy for you. So we've got a new question now. All right, let's have a little look at this. Okay, so 64-year-old man, shortness of breath, unable to complete his sentences. He's got a very high smoking history, showing by the fact that he can't remember when he didn't smoke. So, as part of his ABCD assessment, oxygen saturation is conducted and given a reading of 82%. Okay. So let's just go through the options here. 4 litres per minute of a 28% Venturi mask. Okay. 2 litres per minute via nasal cannulae, target stats of 88 to 92%. So we know that he is hypoxic at this point in time, 82%. And through his history, you can assume maybe he has COPD at this point. And you want to assume that because yeah, it seems quite likely that he does. The answer that is correct is the 2 litres per minute via 24% Venturi mask at this point in time with target stats of 88 to 92%. You can eliminate the last 2 options because the target saturation should be 88 to 92% and not 94 to 98%. So let's just talk a little bit more about this. And I'm going to go back to the hypercapnic drive stuff because in this context, we can explore it a bit more deeply. So if you imagine a man comes in and they've got what you think is COPD, like classic history, symptoms, etc. They've got a oxygen saturation of 82%. So what you're really worried about here is giving them too much oxygen. And I'll tell you why. So when you give, if you gave this patient a lot of oxygen, sure, let's say you gave this person like 90%, like 15 litres of oxygen high flow, right? If you did that, sure, his oxygen levels will go up, and they'll go up, let's say, I don't know, to 98%, 99%, okay? This is, if that happens, that is a mistake, because once the oxygen levels go up, because of his COPD state and his long smoking history, his body will be reverting to a hypoxic drive. So as soon as that oxygen level goes up to 98, 99%, his brain will tell him, okay, right, the oxygen levels are quite higher than normal, to be honest. So, I'm going to stop breathing now or lessen my breathing because I've already got loads of oxygen, much more than I'm ever used to. So like, what's the point? And that is really dangerous because that can cause the carbon dioxide levels then to rise because he's not breathing as much. So he's not able to blow off CO2 from his body. So that increases and causes hypercapnia, which is incredibly dangerous and can cause respiratory arrest. And and at that point, it can take escalation up to doing BiPAP or ITU. So that is why that is really important that you nail that sort of ideology in your head, that when it's this kind of situation, you want to go to a Venturi mask and you want to go to 24% Venturi mask, 2 liters, and titrate up from there. And I know and I've said that, and I'm going to contradict myself because this is all with the caveat of hypercapnia, hypoxia kills as well, right? So if the question had said 60% oxygen sats instead of 82%, at that point in time, you give them the high flow oxygen, right? Because hypoxia kills quicker. And at that point in time, if that was what the SBA had said, it would be, okay, right, we need to actually just prioritize getting his oxygen levels up to 88 to 92%. Monitor him with ABGs and then titrate down again. But because his oxygen sats were around the 82% mark, around 88 to 92%, like close, then we do it properly and do it 24% Venturi mask and try and titrate up and have a close look at the ABGs, look at the carbon dioxide level. But if it was, like, as I said before, 60%, you have to give them the high flow oxygen at that point in time. Okay, next question. Okay, let's have a little look here.
So sorry to interrupt. Can you hear me? Hi. None of us can see the Teams chat. We're asking some questions on the Vivox chat, if you can see that.
Sorry. Yeah, sorry. We've been using the Teams one, sending little messages to you. I'll have a look at the Vivox one now and start answering questions.
Okay, so having a look at this question here. So there is a 1-day history of shortness of breath. He denies any leg swelling, recent flights, immobility or surgery. So that is trying to take PE out of the picture. Lung cancer, he has a past medical history, and the main important thing there is lung cancer. He's got distended veins visible on his chest. So this is a classic oncological emergency of superior vena cava obstruction. So the superior vena, it is what it says on the tin. So basically there is a mass that is pushing down on the superior vena cava, causing the swelling of the face, and obviously distended veins visible on his chest as well. So let's just have a little chat about lung cancer. So carcinoma of the bronchus, second most common cancer in the UK. Risk factors: cigarette smoking, so passive smoking, asbestos, and all of those horrible elements as well. Histology, it's kind of a little bit small, but essentially a lung tumour is split into non-small cell and small cell lung cancer. So you've got squamous adenocarcinoma, large cell adenocarcinoma in situ in non-small cell lung cancer, and then small cell lung cancer, it arises from endocrine cells that can secrete hormones. So ACTH can be secreted, causing a Cushing syndrome picture, and other paraneoplastic syndromes can occur as well along with that. So symptoms and signs again. So symptoms: your cough, hemoptysis, very important, shortness of breath, chest pain, and then your classic sort of B symptoms, so feeling tired, lethargy, anorexia, so weight loss. Signs that you want to see, so cachexia, anemia, clubbing, nodes due to potential spread of the cancer, chest signs, you can get consolidation, lung collapse, pleural effusions, and metastatic signs as well. So you can get a bony tenderness, potentially like back pain, hepatomegaly if it's gone to the liver, confusion, fit, CNS signs, so if it's gone to the brain, cerebellar syndrome, and then proximal myopathy and peripheral neuropathy as well. So investigations-wise, chest X-ray is the first investigation ordered. And then on that, you can see peripheral nodule, hilar enlargement, consolidation, effusion, lung mass. CT, and this is the case for most cancers. So like if you're really stuck in a question and it's a staging question, always just go for CT, because you're going to be more often right, to be honest. So you can take the you can look at the cells as well, from the sputum and the pleural fluid. You can do fine needle aspiration or biopsy. You can use ultrasound for that. Bronchoscopy can also be used for biopsy. Lung function tests also assess suitability for lobectomy. So you look at the lung function of the patient and see whether they've got enough reserves for them to take a chunk of their lung out and still be okay and still be able to have a functional, go about their daily life, basically. So over here you can see in the right lower zone, well, middle zone, or right middle zone, you can see that sort of opacification right there. So management differs between the different lung cancers. So in this non-small cell lung cancers, you can use surgery quite effectively sometimes. So a lobectomy, as we previously discussed, can be used with adjuvant chemo or radiotherapy. You can use radical radiotherapy as well as chemotherapy for more advanced ones. And then for small cell lung cancer, chemotherapy is the mainstay of treatment. And to be honest, I know you get tutorials on lung cancer or specialize on it, but this is basically what you need to know for it. So try not to get bogged down with all the different chemotherapeutic agents. Lung cancer referral guidelines. This is incredibly important and very OSCEable, especially with the history that you're trying to pick up. So suspected cancer pathway referral, so an appointment within 2 weeks. If you get someone with a chest X-ray which shows findings suggesting of lung cancer, or somebody aged 40, more than 40 with hemoptysis, and then chest X-ray in 2 weeks, and then you can read the rest there. Obviously, you've got your B symptoms, and you've got chest pain, weight loss, fatigue, cough, stuff that you really think, okay, there's something serious going on here. To be honest, I reckon in your OSCE, you're going to get a history that you need to do, and it's going to be a 2-week wait referral. And that'll either be lung cancer, an upper GI picture, or a lower GI picture. I think apart from that, I don't really see them doing any other history. So try and practice those histories. So alluded to this earlier on, superior vena cava obstruction, oncological emergency, compression of the SVC. So the features would be shortness of breath, swelling of the face, neck, arms, a headache, visual disturbance, raised JVP, maybe a stridor as well, and you can get chest pain. So the management, I've put secure the airway because it is a classic question for UCL to give you superior vena cava obstruction, barn door, you're really happy with yourself, like, yes, I've smashed it, it's such a nuanced thing, and it's going to be, head swelling, they're trying to get me onto a PE direction, but I know it's superior vena cava, and they'll say, what's the most appropriate next step? And you're thinking, right, it's going to be dexamethasone and radiotherapy or balloon venoplasty. And then if it says what's the most appropriate initial or what's the most appropriate next step, it's always going to be securing that airway. So always remember, Dr. ABCDE, this is how they trip you up, because they'll know that you know everything anyway because you're a UCL student, but they'll be like, actually, in that situation, what's the first thing you want to do? And you want to secure that airway. So don't get tripped up. Next question. Okay, let's have a little look now. So yeah, 42-year-old man, 3-month history of a cough, so a chronic cough. So we're getting a little bit worried about that, or very worried about that. He was initially given an inhaler. It's had no effect. So if there's anything to do with asthma, cancel that off the list of options. There is no relevant past medical history, no history of asthma or lung disease in the family. He has smoked 10 a day since adolescence. So he's got a good pack year history going for him actually at this point. So you're quite worried because he's got the pack year history and he's got an unshakable cough, not affected by inhalers at all. So you're kind of thinking, actually, probably not a COPD. This could be something a lot more serious. On examination, doesn't appear distressed or cyanosed. There's no crackles or wheeze. Again, getting away from that COPD or asthma picture. So at this point in time, because of the chronic cough, etc., and looking at the referral guidelines, you want to refer for an urgent chest X-ray. Right, next question. Okay, let's have a little look now. Okay, so 66-year-old retired librarian, so 66, she's confused, coughing up green sputum. It's got a 10-pack year history, bit of a red herring, sorry about that. Observations, so respirate 28, blood pressure 95/55. Okay. So whenever there's a question, so this is a bit of a giveaway for a pneumonia question, they'll often give you these sort of stats, these observations, because they know that you can then just plug it into a curve 65 and just do a calculation at that point in time. So if you have a little look at the curve 65 score of this patient here, so 66, 1 point for being above 65. They're confused, that's 2 points. Respiratory rate not high enough for a point, and 55 diastolic is less than 60, so that's another point. So that's 3 points. And that basically means, right, we need to refer them to a local hospital for admission. Let's just talk a little bit more about pneumonia then, shall we? Okay, so the definition. So an acute lower respiratory tract infection associated with fever, symptoms and signs in the chest, and abnormalities on chest X-ray. Bacterial pneumonia is the most common type. Well, streptococcal pneumonia. Types of pneumonia. So you can get community acquired, hospital acquired. So that's defined as more than 48 hours after hospital admission. Aspiration pneumonia. So that is more for people who have loss of control of their airways. So people with stroke or bulbar palsies, esophageal disease. So they can get regurgitation. And in immunocompromised patients as well. So you can get PCP in patients with HIV, so pneumocystis, pneumonia. So, but that is something for next year, so don't worry about that. Symptoms and signs. So symptoms: fever, rigors, malaise, anorexia, shortness of breath, cough, sputum, pleuritic pain. Starting to sound very similar to all the other things. Signs, so you'd get a high temperature, you might get a bit of cyanosis, confusion, obviously part of the score, tachypnea, part of the score as well, hypertension, part of the score, and then you've got signs of consolidation as well. So that can be reduced expansion, dull percussion, increased tactile vocal fremitus or vocal resonance, And then you can also get bronchial breathing as well. And I'd recommend going onto YouTube and just typing in bronchial breathing and just having a listen to that. So investigation, so you want to assess the oxygenation, blood pressure, heart rate, respirate, so just getting their observations going. You can test their sputum for microscopy and culture. Blood tests, so you want to look at their FBCs, look for signs of infection with that. Using these, most importantly, looking at the urea, as that forms part of the score. LFTs, CRP obviously shows an infected picture. Chest X-ray, so that will show consolidation or pleural effusion. Check the urine specifically for Legionella or pneumococcal urinary antigens. That's a niche little fact there. Pleural fluid can also be aspirated for culture as well. And then you can invasive procedures like bronchoscopy are there for those who are immunocompromised or on ITU. So the Curve 65 score, you've probably learned it to death by now if you've done respiratory, or even if you haven't done respiratory. Very simple to follow. So confusion, urea, respirate, blood pressure, and the age of 65. And then very handily there is the mortality rates and the risk groups and what sort of management you need to be doing for each one. Please have a little look at. So let's go on to the next question. Okay, let's move on. So this is an annoying question. It's kind of one that you know or you don't, but hopefully now you know. And I guess before finals, I was kind of like, yeah, UCL are nice and they don't really ask these sort of questions. But doing that finals SBA paper, it is good to know this sort of like niche fact. I'll just leave that there. So he's got green sputum. He's got a high temperature. You're looking at some sort of pneumonia picture here. You know that he's homeless and he's had previous admissions of alcohol intoxication. So you know that he's potentially an alcoholic. So you've done the ABCD assessment, oral chest X-ray shows consolidation. So you're like, okay, this is a pneumonia picture of somebody who's got a history of alcoholism or is actually an alcoholic currently. So the most likely organism would be Klebsiella. Because that is the most common cause of pneumonia in alcoholics. The others, so TB doesn't really fit the picture. There's no hemoptysis, weight loss, any foreign travel, etc. Although he is homeless, but and TB is prevalent in the homeless population, but not really the right sort of symptoms. Legionella, that's a classic one. Like you just go somewhere which has air conditioning or just a hot country. Chlamydia psittaci, I don't know if I pronounced that right, but parrots, who knew, might come up, who knows. We got a beetroot question in finals. I'm still annoyed by that. And pneumocystis jirovecii, as I explained before, immunocompromised people, and you'll learn that in your HIV gum module next year. So pneumonia management, kind of touched on it just before there. So if it's 0 to 1 score, then antibiotics at home. If it's a score of 2, then oral antibiotics at hospital. And then if it's 3+, you'd want IV antibiotics at hospital and potential escalation to ITU as well. Good. And there's a little table there from the handbook. I don't think you really need to learn it, to be honest. I think what's on the slide is plenty, to be honest. Okay, next question. Again, Radiopedia coming up with a great chest X-ray here. We'll just take a little 5-minute break after this one. Been going on for a while. Okay, let's move on. So, person who is complaining of shortness of breath, they've got stony, dull percussion. Whenever you hear stony, dull percussion, always think, okay, there might be an effusion. And then once you look at the chest X-ray, you can see that on the right side there is an opacity there, and with a meniscus, which kind of shows, okay, there's some fluid in the pleura. So everything points towards a pleural effusion. What's the most appropriate initial management of their shortness of breath? So you want to aspirate the fluid. Okay, so let's just take a couple minutes of break there, a few minutes of break, and then we can go on. Final 2 topics shouldn't take that long, to be honest. I know we're all very busy, probably tired of me talking as well. Ed, do you have any questions for maybe Dr. Dave that you want to flag up now, or all good?
Yeah, while we're having a break, I will do. I've been trying to answer some of them in the VVOX. Someone's asked a really good question. Would tapping actually manage the shortness of breath due to the effusion, or would drainage do this better?
Go on, Dr. Dave.
I was just going to say, so a diagnostic tap won't really help the breathlessness, because all you're doing is taking off between 50 and 100 mils of fluid, enough to test for it. If you're doing a therapeutic aspiration, then you can provide symptomatic relief, because you can drain up to 1.5 litres. So we often do that for malignant effusions, where we just want to make someone symptomatically a bit better.
Okay.
But in terms of this question, I think what it means is a diagnostic aspiration and not a therapeutic aspiration, because otherwise it would be a really mean question and answer. So I would expect them to word it a bit more accurately, because otherwise it can cause confusion.
Yeah, I think with that question, I was kind of trying to point at more the initial management of the shortness of breath.
Exactly.
Yeah, that is essentially like the kind of nuanced thing that you said will kind of try and throw at you.
Yeah.
But yeah, you're completely right, whoever said that, and your thoughts.
And there were a few questions earlier about something that, to be honest, still baffles me. If you have an acutely unwell patient who may or may not have COPD, and if they do, may or may not be a retainer, what kind of guides you in your thinking as to Venturi versus high flow? What would be an arbitrary cutoff if there is one? Basically, how do you approach it? 'Cause it's a bit of a tough one.
Yeah, it's exactly. It's about how you approach it. So look, the safest thing, and what A&E doctors and what paramedics will always say, is give them the oxygen, because hypoxia kills. Hypercarbia makes people sick and can land them up in intensive care, but hypoxia kills. So if you don't know someone's history and you don't know that they've got COPD, then absolutely what you do is you give them oxygen and you get their saturations up. Actually, if someone is that unwell and they're in A&E, they should get a gas very quickly. You put a cannula in, and at the very least, you get a venous gas off. So from a practical perspective, when you pull off that venous gas, you can estimate if someone is likely to retain carbon dioxide. From a kind of doing things by the book and thinking about your finals exams, because obviously there's always a slight nuance to these that comes across when you're actually working. In terms of actually working up a patient from a final exam perspective, so I think they would give you a gas that would show you a raised PCO2 and or a raised bicarbonate, which would show you that someone is a chronic carbon dioxide retainer. So you need to know your cutoffs in terms of your CO2 and your bicarb. So a CO2 of more than 6.5 is someone who retains carbon dioxide, and a bicarb of more than 28 is someone who chronically retains carbon dioxide. Anyone who is needing oxygen as part of your workup should have an arterial blood gas as well. So again, even if you're over-oxygenating them, if that is part of your initial workup, part of your ABCDE approach, then you will very quickly know if someone is a type 2 retainer, and therefore you need to start titrating the oxygen down.
Okay, brilliant. We haven't got any more questions. If people want to send them in now, we can go through them. Otherwise, I guess we can carry on. We haven't got too many slides left.
Yeah, we don't have too many slides left. If there's some more questions that Dr. Dave will field at the end, there's not much to go now. So pleural effusion. By definition, effusion is fluid in the pleural space. Some bits of terminology here. So hemothorax, blood in the pleural space, pus and pyema. Chylothorax is chyli in the pleural space, and blood and air in the pleural space would be a hemopneumothorax. And a pleural effusion is split up into either a transudate or an exudate. So, transudate happens when there's less than 25 grams per litre of protein in the pleural fluid that is taken off, aspirated. And so an exudate is when there's more than 35 grams per litre of protein in there. Now, why that is important is because you have different management for both different types, and there are different causes for the different types, which I will go into, but I'll talk a little bit more about it here. So transudate stuff, the way I like to think of it is in terms of fluid getting into the pleural space, proteins can only go through when there's a leaky capillary, is the way I like to think about it. So in terms of a transudate, when there's less protein coming through, you know the capillaries aren't that leaky. So it's more of a hydrostatic pressure within the capillaries that is causing the effusion to occur. And that can be due to renal failure, liver failure. It can be due to other causes as well, causing that increase in hydrostatic pressure. An exudate, on the other hand, would give leaky capillaries, which would have bigger holes in the capillary, which would cause more and more protein to go into that pleural space. So things that cause that: infection, malignancy, TB, so pneumonia can also cause it, and that's the way I like to kind of think about it. So I hear you ask, what happens if it's between 25 and 35? So here's the LIGHTS criteria for you. So there's a little grey area between 25 to 35, and essentially in that grey area you apply this criteria to figure out if it's a transudate or an exudate. So as we're seeing in the table, an exudative pleural effusion meets one or more of the following criteria. So that is pleural fluid protein divided by serum protein of above 0.5, lactate dehydrogenase in the pleura divided by serum lactate dehydrogenase of more than 0.6, or pleural fluid LDH more than 2/3 of the upper normal limit of serum LDH. Now, what I've just said there sounds really, really complicated, but the way I like to think of it is an exudate would give you leaky capillaries, back to that analogy, leaky capillaries, and because of that leakiness, you're going to get more protein going into the effusion, or more lactate dehydrogenase going into the effusion as well. And that's how I like to think of LIGHTS criteria. So I remember it's around 0.5 or 0.6, but that is essentially what is happening. There's more gaps in an exudate, and more gaps in the capillaries in an exudate, and that causes the increase in protein or lactate dehydrogenase going into the pleural effusion. So I've just split it up here. So the causes, so as I said before, so transudate increase venous pressure, Hypoproteinemia, so through osmosis, the effusion goes into the pleural fluid. Meague syndrome is forgotten the triad for that, with like ovarian problems as well. It's very niche. Transudate hypothyroidism as well can cause it. Exudate stuff, as I said before, it's your like infection, inflammation, malignancy, causing those leaky capillaries and causing an exudative pleural effusion. Symptoms and signs, again, so symptoms, they can be asymptomatic. Normally you'll have, if it's big enough, have shortness of breath, a non-productive cough, pleuristic chest pain. Signs, so you'll have decreased lung expansion, a stony, dull percussion. That is stony, dull percussion. If anything you take from pleural effusion, take stony, dull, because if that comes up, you're kind of thinking, okay, it's probably an effusion. Decreased breath sounds, decreased tactile vocal fremitus and decreased vocal resonance, bronchial breathing above the effusion. So the way I like to think about it is that because there's a pleural effusion, there's more of a barrier in terms of hearing breath sounds or tactile vocal fremitus or vocal resonance. So because there's more of a barrier there, you're not as likely to hear those things. So pleural effusion, the investigation, so chest x-ray, really important. You can see the meniscus and the opacification. You can also do a CT, pleural biopsy, as we said before, diagnostic aspiration of pleural fluid guided by ultrasound. Pleural infection is indicated if fluid is cloudy or if the pH is less than 7.2. And that's quite an important thing to know, because that can instantly basically just tell you, okay, right, there's probably an exudative process going on right now. So management, so obviously you want to aspirate and drain the fluid, and then you can give opioids to relieve breathlessness. Drainage is said there. Pleurodesis as well is for recurrent pleural effusion, so when there's the problem keeps on happening. And a new drug, Dornis alpha, may help with empyema as well, but I think that's quite niche, so don't worry about that. New question? All right, let's have a little look. Okay, good. So cloudy fluid with a pH of 7.1 would show, an infective process is occurring, which is causing the pleural effusion. So if we have a look here, right, before we move on, sepsis. So this is a classic thing that UCL will throw in, and something that you need to be aware of, not only in SBAs, but also very osteable in your Dr. ABCD stations. So we know this person is sweaty, they're tachycardic, they've got, and they're hypotensive. So you're really worried about this person, and they've got a temperature of 38.2 degrees. So you know there's some sort of infection going on, and they are becoming hemodynamically unstable at this point in time. So what you'd want to do next would be the sepsis 6 protocol. Okay, next question. Okay, so we'll just have a little look here. Okay, so really, really important question. I think probably talked about this situation about 3 or 4 times now in the lecture, and because it's so important and something that will come up in your exams. So you're in F1, asthmatic episode. She's given burst therapy, driven with oxygen. PaCO2 in the first 20 minutes was 4.1. The next one has shown an increase in oxygen, fair enough, but the PaCO2 has actually also increased as well. So this is a near fatal, life-threatening episode right now, and they need to have ITU admission arranged. Whenever you see the carbon dioxide level staying normal or going up, especially in an SBA where they're doing serial ABGs, the thing you need to be looking at is the carbon dioxide level. And more often than not, in fact, I'll bet that every time there will be either the same CO2 or more, and that will mean, right, we need to escalate. So you'd arrange ITU admission as well at this point to ventilate the patient and intubate. So that just ties us off to respiratory failure, last topic. So definition, so it occurs when gas exchange is inadequate, resulting in hypoxia. So respiratory failure can be split into 2 sections. So type 1 is when the PaCO2 is less than 6, and type 2 is when the PaCO2 is more than 6, so they're hypercapnic. So along with being hypoxic, they're also hypercapnic in type 2. So again, hypoxia features, so you'd get the dyspnea, restlessness, agitation, confusion, central cyanosis because of the lack of the oxygen. Long-standing hypoxia, which can occur in COPD. You can get cor pulmonale, polycythemia, pulmonary hypertension. Hypercapnia, as you can see, is a bit more nuanced, and Dr. Dave was saying before about how it can cause a patient to be really sick. You can see that to the latter stages can cause coma, confusion, drowsiness, headache, etc. Bounding pulse is a really specific thing that I'm sure you guys have drilled into yourselves in terms of like doing OSCE practice and feeling for a bounding pulse, because CO2 is high, tremor, flap, CO2 is high. So that's stuff for the OSCE. Investigations that you want to do in respiratory failure. So you want to do bloods, just get an overview. The main thing there, obviously, the ABG will guide you as to what sort of treatments you need to be giving in terms of what kind of oxygen delivery you should be giving, as Dr. Dave said before as well. So radiology, chest X-ray, so that could give you the indication of the respiratory failure. For example, it could be hyperinflated chest for COPD, etc. Microbiology can be used as well to look at the cause of the respiratory failure. Spirometry as well, looking if there's COPD, shows an obstructive picture, whereas neuromuscular disease would show a restrictive picture. So just a quick management heads up here. So type 1, give them oxygen. Assisted ventilation given if the oxygen levels is less than 8 despite 60% oxygen. Type 2, so as we've alluded to before many times with the COPD patient, you need to give controlled oxygen therapy. So you start at 24% oxygen, recheck the ABG, and if the PaCO2 is steady or low, you can give higher oxygen because they're not becoming hypercapnic. But if the PaCO2 has increased, then you may have to then give them assisted ventilation. So that could be an IV. Okay. No, always treat the underlying cause. There will be an underlying cause for respiratory failure. And as soon as you get that sorted, you have to get the underlying thing sorted, basically, otherwise it will keep on happening. So for COPD, that could be giving them the inhaled therapy, long-term oxygenation therapy, etc., etc. That's the end. I hope you enjoyed that, the first one of the series. I'm sorry if it was a little bit quick. I know that your guys' evenings are precious. If there's any questions, let us know, and please fill in the feedback forms as well. I think they'll be posted on the chat and possibly on Facebook as well.
Yeah, I'll send them now.
If you could do that, that's great. Ed, are there any questions for Dr. Dave?
Yeah, is there a difference between which types of NIV you use for the different types of respiratory failure, i.e. CPAP versus BiPAP? Yeah, and that is a really good question.
That's an excellent question. I'm not sure I knew the difference between BiPAP and CPAP at medical school. Yeah, absolutely. So, and it's not just about the different types of respiratory failure, but it's also the underlying cause, which goes back to one of Shwetabh's last slides about always treat the underlying cause. So CPAP is very much used for type 1 respiratory failure. You cannot use CPAP for any form of type 2 respiratory failure. You must either use BiPAP or intubate and ventilate the patient, which is obviously the next step for type 1 respiratory failure as well. CPAP is continuous positive airway pressure, so essentially just helps to keep the airways open so you get better gas exchange. BiPAP is bi-level positive airway pressure, and it actually helps to ventilate the patient. So not only do they get better oxygenation, but you actually remove carbon dioxide, and that's the main difference between the two, and that's why we use BiPAP for type 2 and CPAP for type 1.
Brilliant. We've got another question. Please, would you clarify the exact roles of aspiration and drainage in the management of effusions?
Yeah, so if you get someone with a pleural effusion, essentially, first of all, you need to know, is it a transudate or an exudate? So the way to do that would be a diagnostic tap or a diagnostic aspiration. We can then do a therapeutic aspiration, particularly if we know it's a transudate. So for example, patients who come in with recurrent episodes of shortness of breath because of heart failure or renal failure, and they're found to have a large pleural effusion on the right. If they just need a bit of fluid to be taken off whilst they're being diuresed or offloaded, we can do a therapeutic aspiration, take off a litre. It makes them feel better, and it gives the medical teams a chance to offload the excess fluid. A drain is put in when we want to drain the fluid to dryness. We can also take samples of fluid from that and send it off for a diagnosis. So particularly if we have a suspicion that someone has a malignancy, we will often just go straight to a drain, take that fluid, take samples of fluid at the same time as putting the drain in. And once they've drained to dryness, we will then make a decision about what we want to do at that point to stop the fluid from coming back. Other reasons to drain to dryness is if someone has an empyema, which was one of the sample questions. So again, if someone has an empyema, we have to drain that because otherwise that patient will just not get better. And that would be another reason to put a drain in. Hopefully that answers the question.
That's great, thanks. There's another question. Is the antibiotic of choice in an infective exacerbation of COPD the same as that in pneumonia, community pneumonia, I guess?
So every hospital will actually have their own protocols for what antibiotics they want you to give in a community-acquired pneumonia based on the CURB-65 score. That will slightly also depend on, so the reason every hospital has their own policy is it will be based on the local microbiology and the local sensitivities and resistances. But as a general rule of thumb, CURB-65 score of 0 or 1 will either be oral amoxicillin or oral co-amoxiclav, clarithromycin if they're penicillin allergic. If you score 2 or more, then that generally means a hospital admission, either hospital admission, oral antibiotics and monitoring, or 24 hours or 48 hours of IVs and then switch to orals. With infective exacerbations of COPD, oral antibiotics are normally enough. Again, some hospitals might have a local microbiology or antibiotic protocol that advises you what they want to be given if there isn't a pneumonia. Remember, your definition of a pneumonia includes radiological changes. So you can have an exacerbation of COPD with a pneumonia, or you can have an infective exacerbation of COPD without a pneumonia. And so that's where the antibiotic protocols can slightly differ. So it's very much about going by the local hospital policy, but most oral broad spectrum antibiotics like amoxicillin, clarithromycin, doxycycline will work for an infective exacerbation of COPD.
We've got 2 more. Is bronchodilator reversibility in asthma either 12% change or 250 mils, i.e. can you have one or do you need both?
So you can have one or the other, that's absolutely fine. And in fact, we tend to, I mean, that's the official guidance, but to be honest, in practice, if someone has at least a 10% change, we'll usually accept that they've got some element of airway reversibility or bronchodilator reversibility, and that they have an asthmatic element to their airways disease. But it can be one or the other, that's fine. We tend to go with the percentage, if I'm honest, rather than the absolute volumes.
Okay, yeah, but for SBAs, they're just values that are worth rote learning, right? Next question, what are the indications for prophylactic antibiotics in COPD patients?
So increasing, and actually there's a lot of research into it. So recently there were some big papers and studies about the role of azithromycin in various lung diseases. First there was bronchiectasis, and now there is a lot of interest in azithromycin in COPD. I mean, generally, any other antibiotic we don't tend to use as a prophylactic antibiotic in COPD. The reason there's a lot of interest in azithromycin is because it also has an anti-inflammatory effect. There was also a recent study out about the use of azithromycin in severe asthma. And that's why it's kind of led, because of the results shown with bronchiectasis and then asthma, there's interest in COPD. So it's not just its antimicrobial benefit, it's also got an anti-inflammatory benefit as well. Beyond that, there is very little evidence that prophylactic antibiotics works in pure COPD. Often what will happen is that people with chronic COPD or chronic asthma develop an element of bronchiectasis, which is essentially widened airways, which produces more mucus. More mucus means more infections. And so patients who've got an element of bronchiectasis will often benefit from prophylactic antibiotics. As far as I'm aware, there's very little good evidence for prophylactic antibiotics in pure COPD.
Okay, we haven't got any more questions at the moment. What I wanted to say to the students was, it's the time of the session that I genuinely hate and I cringe myself at. A lot of you have sent in feedback. If the rest of you wouldn't mind doing it, we honestly pay attention to all of it and try and incorporate it as much as we can. There's been some really useful stuff said in the VVox Q&A that we're going to focus on ahead of next week, like distributing the slides beforehand and what have you. But yeah, if you please do it, you know, it's just really great for us, and it'll be better for you guys as well, because we basically tailor it to your kind of preferences as much as we can. Yeah, I'll resend the link.
Yeah, and just one more, just thanks so much to Dr. Dave for coming in and, you know, giving up part of your evening to sit here and listen to me witter on about something that you obviously know a lot more about. So yeah, thank you so much. I know that we appreciate it as SPLICE team, and then obviously the 4th-year students love it as well, because it's so hard to get people answering their questions in these sort of revision lectures.
No, I mean, thank you for inviting me, and I'd just like to say that you guys as a team have put on a brilliant effort. I thought the slides were excellent. So yeah, well done to a very informative evening.
It's wholesome.
Very wholesome, very wholesome. Lovely. Well,
yeah, we've got no more questions. So we'll leave
your evening, everyone.
Yeah, thanks for coming, everyone. Maybe see you later in the week. And thanks, Dr. Dave. It's been humbling to listen to you just smash these people's questions. Will all sessions be 6 p.m? It depends. We'll do it as early as we can. If we have to fit it in amongst certain other sessions that might be going on, then we'll start a bit earlier, like 5:30. But yeah, 5:30. The roundabout answer, yeah. So 5:30 or 6 usually. Which is a bit exhausting, but we have to fit it around med school and clinicians' working days. So it's not ideal, but we just got to make do.
All right, lovely.
Cool. All right, thanks everyone.
Thank you very much, everyone.